Good afternoon all. My name is Samya Lakis and I'm here to discuss vertebral body tethering in its essence. Tethering in itself can refer to spinal cord tethering, which is a form of spina bifida or spinal dysraphism, and really is managed by the Spina Bifida Clinic. Whereas vertebral body tethering is a surgical technique popularised really in the last 10 years by San Diego surgeon Peter Newton. And whilst he did a lot of the animal and original surgical procedures in this regard, it's grown beyond his control, and he's watched it popularised at various institutions, including other institutions in Germany and Turkey, and expanded within its technique. So is it new? And the answer is no. It's a strategy that's been discussed since the 1950s with previous forms as hemiepiphyseodesis, so unilateral screws and rods, and anterior vertebral body staple. However, there were problems with loosening and under correction, as staples really only seem to work on the more moderate flexible curves, and despite this they loosened and migrated. This original article looking at the potential is well worth a read. The best article and the sanest article that I'd recommend that you read would be this one published by Peter just this year. It's an open access article, and he clearly defines the goals to limit deformity progression and produce a correction to create a more normal spinal contour. He describes the aim is to preserve function and motion through these segments, and to try and do this through creating healthy discs, as other alternate for these curves or severe curves or operative curves would be a fusion, whether it's performed anteriorly or posteriorly, is dependent on the curve or the surgical experience of the centre. So vertebral body tethering is a growth modulation technique, and there's good evidence on basic science data and animal experimental studies, and also increasing clinical evidence in patient cohorts and populations. So the principles are that a screw is placed across the anterior vertebral bodies in a plane relative to the scoliotic deformity, with care to not overly penetrate the other side and cause problems with the aorta and other larger vessels, or be careful with rotation so you don't end up in a canal or anything concerning. And then once those screws are placed, a ultra high molecular weight polyethylene weave or tether, as it's called, is tensioned across. And the idea is that this flexible tether facilitates disc health and nutrition. So we get compression across the convexity or the outside of the curve, and this detensions the concavity and allows that to grow out. And it's this application of the Heuter-Volkmann principle which has been shown to actually be effective, although unpredictable, unfortunately. So what you see here is evidence of a standard right thoracic curve, a Lenke 1A, as we'd call it in the classification system. And the growth modulation is thought to be increased pressures on the concavity and decreased pressures on the convexity, meaning that there's less growth anteriorly in the end plates on the concavity and more on the convexity. And the idea is to reverse that through use of the tether and allow it to grow out. And the hope is that this would be predictable, but unfortunately it's not. As any growth modulation strategy in the body and the spine is unpredictable and has complications, unfortunately. So who benefits? Currently the literature would suggest a curve of 45 to 65 degrees in a Sanders 3-4 patient with relative flattening, not kyphosis, as an anterior compression force will increase the kyphosis. So the classic lordotic or flat adolescent idiopathic curve is the best one. The difficulty is you can't operate too young, and that's why the Sanders or score or a left-hand bone age is important, because you can overcorrect it. The curve actually still needs to be flexible, with some proponents suggesting bending down to less than 30 degrees, as the bigger curves or the stiffer curves seem to break all the time, which is unfortunate, as it's really these young adolescents that are needing potential growth modulation to be of benefit to them as they're looking at early fusion. With regards to curve pattern, thoracic curves are amenable, but not the high thoracic. Thoracolumbar curves are also amenable, but the question is what to do with those big S-shaped curves or double major curves or the lumbar curves, as the increased mobility in the lumbar spine is associated with higher tether breakage. And some proponents are now putting 2 screws and 2 tethers in the lumbar spine to try and decrease breakage rates. However, I can't see this as being fusionless or facilitating motion, although the jury's still out, really. So what are the risks? The risks are that of anterior surgery, whether you do it thoracoscopic or mini open, whether you do it thoracic, cross the diaphragm or into the abdomen. There's a very high fluoro time, so increased radiation dose for these young individuals. And there's a steep learning curve with some of the technical considerations discussed previously. Thoracic curves, it's very hard to go above T5 as you end up in the axilla. And curves above this, or elevation of the left shoulder or an upper thoracic curve, you can't access it as you're ending up just above the, just higher than the axilla and potentially into the neck. So short to medium term data suggests that there's risks of overcorrection, undercorrection, tether breakage, and there's a chance of conversion to fusion. So you have to have a patient cohort that understands these risks and understands that there potential is for revision surgery. And this isn't for everyone, especially when it comes to spinal surgery. So this is an example of a young patient, clearly open triradiates, those growth plates in and around the hips, and good result initially, and then evidence of overcorrection. And this can produce a significant clinical deformity and requires revision surgery to basically release that tether with a small rebound. So with regards to the evidence, there's several cohorts that are well worth looking at, and the published studies are minimal despite all the talk. So Samdani and al. Looked at 32 patients. They did an initial preliminary one, but this is well worth mentioning, with an average COP of 43 degrees, and they got it down to 18 degrees at 1 year. Cabeto showed that out of 20 patients, they were looking at the higher ranges, and they got 60 degrees on average down to 23 degrees at 2 years. And Peter Newton published on 17 patients with an average of 52 degrees down to 27 degrees at 2 to 4 years. Samdani et al. Presented recently in the SRS just last year, 53 patients who had a COB of 40 degrees. That was down to 16 at 4 years. However, the 40 degrees was average, which suggests that they're operating on very low curves originally. So the challenges, as mentioned previously, are the high thoracic curves with access. For all thoracolumbar curves, you'd need to cross the diaphragm, which we're all comfortable doing if we do anterior surgery. And consideration of how to instrument the lumbar curves. We now know that you need to overlap your tether, so you're needing access on both sides. And in the lumbar curves, the question is, do you end at 3 or 4? And a lot of them are ending at 4, whereas we avoid instrumenting down to 4 wherever possible if we're doing a fusion. And if you're using double screws and double tethers and they fail, then that leaves you in a very difficult position. So what happens if you Google VBT? Well, the first thing that comes up is velocity based training, which might be of relevance to all of the physios and everyone here, however isn't really what you were talking about. However, Google offers you an option of VBT surgery, and you find lots of advertising from this group where she was smiling right after surgery, to some of the allied health where we're having the chiropractors really advertise their linkages with surgeons and promoting VBT as a better option. And if you look at the type of curves that they're operating on, some of them are quite small magnitude curves, which we would traditionally consider bracing in these curves. And bracing has a 70 to 80% success rate depending on compliance. So with a very low number needed to treat you're treating 3 patients to avoid 1 surgery, and the cost of bracing is probably less than that of spinal surgery. Other groups such as this group offer to review your case from all around the world and call their surgery anterior scoliosis correction, not VBT, as they offer this surgery, as I said, all around the world, but to all patients, including the big stiff curves, and to adults. When you look at the fine print, they talk about spinal realignment, and they also talk about additional advanced corrective techniques for these inflexible curves, which in reality is a discectomy. And this is a technique that we're all comfortable with as spine surgeons, but the reality is that it creates a fusion. So looking at this as fusionless surgery is probably a bit misleading. So what about the Australian experience? Look, Jeff Askin in Brisbane pioneered thoracoscopic anterior fusion and has a very skilled team up there, and he's extended this successfully to VBT surgery, but mainly in the thoracic group. Jeff will happily go down to L2. Andrew Cree in Sydney has probably the largest case series in Australia, with a preliminary presentation of results at Queenstown. However, it's a very early experience. And I'm aware of some surgeons performing it in Melbourne and Adelaide. The costings is questionable, as for paediatrics there's no rebatable code under MBS, and as far as I'm aware the tether's not listed under the prosthesis list, so that's an out-of-pocket expense for the patient. So just to show you that it's not the only device available, I think the utilisation of fusionless surgery or internal correction implants, as this ApiFix is expanding the market. So for the more moderate curves or low-grade severe, if you use the cutoff for severe as operative, there are a number of alternatives promoting themselves. However, they only have short-term data, and in this regard, the device here is only really advertised or promoted by user groups associated with the company. So we'll need to work this one out further. In conclusion, look, tethering is promising as a growth modulation surgery. It is experimental, and the ideal indication long-term outcomes are still to be identified. You need patients that are keen to be on the cutting edge and happy to have revision surgery, as that's the very real risk. There are a number of alternate options for the moderate or flexible curve, and my concern is that we're going to translate previous patients who would be braced or non-operative into operative, and this will come at increased cost to limited health resources, and potentially to increase risk to the patients themselves. I think translation into the adult skeletally mature market should be met with scepticism for the reasons previously elaborated. Thank you for your time. Any questions?